I'm honored to introduce Dr. Bradley Warady. His extraordinary bio is listed in the app for you to review. ASF is really fortunate to have Dr. Warady serve on our medical advisory committee. He's also currently advising us on a project to document the insights and experiences of pediatric Alport patients. So welcome, Dr. Warady. We're really grateful you're here.
Thanks, Lisa. I've been sitting here while you're talking, looking at all the chats that are already going on and people talking to one another and excited to be at the meeting. So it's terrific. I think I'd like to just spend a little time just watching all the chats because they are so exciting. So I'm going to share my screen here. Okay. And I'm going to spend the first 20 minutes giving you some insights from my own practice in terms of caring for kids with Alport syndrome as well as with chronic kidney disease in general. And this is the way I practice. And I think maybe it'll provide you with some lessons, if you will, which you can use and maybe take back to your own programs to try to optimize the care for you as patients or for your kids as parents. I want to show you this slide first. I am from Kansas City, and I'm showing you this slide not to just highlight the fact that we are the Super Bowl champions, which we are, but I want to highlight the fact that no one individual on this team allowed for the Chiefs to become Super Bowl champions. Patrick Mahomes is a great quarterback, but he needed other members of the team. This was a team approach. And I think that you're going to hear that theme as we continue through my presentation, that it really takes a team to provide optimal care for children with chronic kidney disease and Alport syndrome. And we're going to talk about those team members as we proceed. This is my team at Children's Mercy, and it's made up of physicians and nurses and dietitians and social workers and psychologists and psychiatrists and pharmacists. And all of those team members need to work with other team members, specifically patients and families, to provide the best care. And this is where I work. This is Children's Mercy Hospital in the middle of Kansas City, Missouri. And this is the way the hospital looked about 2 years ago. And at the end of this presentation, I'm going to show you sort of an updated slide and tell you why that new picture is so significant. So let's start with the case history. John is a 17-year-old with Alport syndrome, having been diagnosed at age 5 years. John has two uncles with Alport syndrome, both of whom had received a kidney transplant. Now, in addition to hearing loss, which has prompted John's use of hearing aids, he has chronic kidney disease and a glomerular filtration rate of 40 mils per minute per 1.73 meters squared. Excuse me. As a result of his medical needs, John is regularly reminded of his Alport syndrome and, if you will, the burden of chronic kidney disease. And he often feels isolated because of his disorder, but he is commonly hesitant to talk to others about his feelings other than maybe his parents. He's been prescribed an increasing number of medications as his kidney function has decreased, some of which he doesn't take as prescribed because of the associated side effects with taking them. And then finally, plans are being made for John's transition to adult care, and both him and his parents are a bit anxious about the move. And so I think this case brings to the forefront a number of issues that I commonly see in patients that I care for, and issues that we're going to be talking about over the next few minutes. Now, this slide provides you what I call the life course of pediatric-onset chronic kidney disease, or CKD. And it just highlights a number of factors that influence the progression of this chronic kidney disease in children. Here you can see there are certainly genetic causes, and you all know that there's genetic causes of Alport syndrome. And then things occur over the course of childhood that lead to either chronic kidney disease or end-stage renal disease, or ESRD. One of the more important issues, again, is that transition from pediatric to adult care, which can strongly influence the outcome of patients. So we're going to talk about that. And another important issue, is that of treatment non-adherence that sometimes occur with medications, which again can have a significant impact. And we're going to talk about what might give rise to these issues on occasion. I'm not going to spend a lot of time talking about Alport syndrome specifically, but I wanted to give you a few slides about the insights and the classification and pathophysiology of Alport syndrome. I suspect that many of you have some of this information from your own centers. As you know, Alport syndrome is the second most common inherited cause of kidney failure after PKD, or polycystic kidney disease. And Alport syndrome may affect as many as 60,000 people in the United States. And in fact, it may be even more. It's probably an underestimation because some patients have never been tested. Classically, as you may know, when we look at Alport syndrome, we know it's due to a mutation of a specific gene, either what's called the COL4A5 mutation, which is X-linked Alport syndrome, where it's passed, if you will, from mothers to sons, or a mutation of one of these two genes, COL4A3 or COL4A4. And again, if each parent has this mutation in one of those genes, generally that means that every one of their children has a 25% chance of developing Alport syndrome. And the symptoms early on are hematuria, or blood in the urine, loss of kidney function, hearing loss, or eye abnormalities. Now, in the new classification, we now recognize that women are not just carriers. Women who have sons with Alport syndrome, they too can have Alport syndrome, and they have a risk of developing kidney failure. And individuals who have a mutation of just one of these two genes, COL4A3 or COL4A4, they too can have Alport syndrome, but it's somewhat milder in many situations. So the number of patients with Alport syndrome, or again, who have an abnormality of what we call type 4 collagen, is really much higher than historically has been recognized. This slide is nice because it points out the prevalence. How frequently do we see these different kinds of disorders in terms of this type 4 collagen mutation? And then what's the risk of kidney failure? So this is the classic Alport syndrome that's passed on from mom to son. You can see that out of all the patients with this type 4 collagen abnormality, it only makes up 6%, but 100% of these patients currently go on to end-stage kidney disease. Likewise, if we look at the form of Alport syndrome where each parent has the gene themselves, they're carriers, but every one of their children has a 25% risk. If they develop Alport syndrome, small number of the patients, but again, they all go on to have kidney failure. Whereas in the other forms of Alport syndrome, a lesser risk of kidney failure, but you can see those patients who have just one gene abnormality and it's not the X-linked, again, they make up the bulk of the patients with abnormalities of type 4 collagen. The reason I really show you this slide is to point out the fact that the development of end-stage kidney disease can occur between 20 and 100% of the patients with Alport syndrome. And that's why it's so important that we are addressing kidney management in patients with Alport syndrome. So we know we start with hematuria in the patients, or blood in the urine. We go on potentially to have microalbuminuria, which is a small amount of protein or greater amounts of protein, for which many of the patients, the majority of the patients, are treated with an ACE inhibitor or an ARB. Some of those patients will go on to have declining kidney function or declining GFR, and some will develop end-stage renal disease or end-stage kidney disease. And then some patients will have abnormalities of the lens of their eye, or lenticonus, or a hearing loss. The last slide I want to show you sort of on pathophysiology is this. When we look at the reasons why the kidney fails in patients with Alport syndrome, historically we thought there was only a pressure-mediated injury. You can see this is the glomerulus. This is the filter of the kidney. There are about 1 million filters in each kidney, and these are the blood vessels that go into that glomerulus. The afferent, or the blood vessel that goes into the glomerulus, you can see it's dilated. The efferent that comes out of the glomerulus, you can see it's constricted. And this leads to high pressure in this glomerulus and injury. And that's one of the reasons you use ACEs and ARBs, to decrease the pressure in this glomerulus. But we also now recognize that inflammation is another important factor that may influence the worsening of kidney function in patients with Alport syndrome. And so new work is being carried out now to look at the impact of decreasing inflammation in the kidney and hopefully the allowance of preservation of kidney function in patients with Alport syndrome and other causes of chronic kidney disease. Now, it's important that we measure kidney function when we are following children with chronic kidney disease with Alport syndrome. We could do it this way, collecting urine in all these kids, but you can see logistically this may be a bit difficult, so we don't do this. So what we do is we estimate their GFR, their glomerular filtration rate. And this is a measure of kidney function that's determined by using a blood test. And all of you patients should know what your GFR is. And parents of children, you should know what your child's GFR is. Now, in my program, we give our patients this sheet that describes for them what their GFR is. So stage 1 kidney disease is a GFR of 90 or higher. That's a normal GFR, a normal kidney function, as reflected by all the green in this picture. But as kidney function worsened, it goes from stage 1 all the way down to stage 5. Stage 5 is when you need dialysis or transplantation. And you could see that the number of GFR progressively decreases as the stage increases from 1 through 5. And again, the green in this picture decreases accordingly. So it's very important for everybody in the family, as well as obviously the healthcare providers, to know what your estimated GFR is as part of your kidney management. As a pediatric kidney doctor, what I need to do is to work with my patient and family to treat their bone disease that can occur in the setting of chronic kidney disease, to treat their blood pressure, manage blood pressure so we have a healthy heart, and to do whatever we can to delay the worsening of kidney function. This is an over-exaggeration of what can happen if you don't control bone disease, but this is a real patient of mine from the past. So if one does not control all of the, again, mineral abnormalities that can occur in a setting of kidney failure as it reflects on bone disease, this is what you can see. So in patients with impaired kidney function or chronic kidney disease, we give those patients calcium, we give those patients vitamin D, and one of the more difficult things that we do is encourage modification of phosphorus intake. High phosphorus levels in the setting of kidney disease can lead to bone disease, can lead to heart disease. And this is the problem. Phosphorus is in almost all the foods that we like. It's in the foods from McDonald's. It's in macaroni and cheese. It's in foods from Taco Bell, and it's in all the dark colas, especially Dr. Pepper. And so here's where that partnership comes into play. The physician and nurses working with the patients and the families and the dietitians to try to modify the diet so that there's not an excessive intake of phosphorus so that bone disease can in fact be controlled. This is a patient with what we have on her is an ambulatory blood pressure monitor. This is a blood pressure monitor that monitors the blood pressure every 30 minutes for 24 hours, day and night. And this is the gold standard of monitoring blood pressures. And we do this in many of our patients, especially those with advanced chronic kidney disease, because some of these patients will have high blood pressure at night while they're asleep and not during the daytime. That's called masked hypertension. And so it's important that we look at that because high blood pressure can have a negative impact on heart function. And so we want to control blood pressure if at all possible. Now I want to show you this slide. I'm going to go through this slowly. This is one of the real medical slides I'm going to show you, but it points out the importance of controlling blood pressure because of its impact on the progression or worsening of chronic kidney disease. So this green line represents those patients who have very good control of their blood pressure, normal blood pressure. This yellow line represents individuals that have fair control, and this red line represents individuals with poor control of their blood pressure. Now, these are not just Alport's patients. These are patients that have chronic kidney disease, all children, and they include patients with Alport syndrome. Here we're looking at time from 0 to 8 years. And here we're looking at the percentage of patients who are not on dialysis, they're not on transplant, and their kidney disease is not worsening. So you can see that those patients who have the best control of their blood pressure, about 90% of them are doing great. Their kidney is not sick, if you will, or it's not worsening in function. They don't need dialysis. They don't need a transplant, 90%. But if we look at those individuals in red who had poor blood pressure control, you can see that only 30% of them are not on dialysis or transplant or have good kidney function that's stable. 70% had worsening of their kidney function. So this study pointed out that it's very important to control blood pressure, to measure blood pressure accurately, because it may have a significant impact on the worsening of kidney function. Now, I've given you a lot of sort of medical background, if you will, but I think one of the most important issues that we always have to address is quality of life. And I think historically that has been underemphasized, if you will, but it's so important. I think that all the treatment recommendations we give are much more successful if we recognize the impact of those recommendations on quality of life. Why do I say that's important to our population of kids? This is from a study where we looked at the health-related quality of life, HRQOL, at children with different disorders. You can see all the different disorders, asthma, rheumatology, diabetes, cardiac disease, cancer, and so on. And then this is from a survey called the PEDS-QL survey, which we utilize in many of our patients to ask them about their quality of life. And there's a total score and then a score about their physical activities. And what I want to show you is this is the quality of life scores of children with chronic kidney disease and children on dialysis. And you could see that for those children on chronic kidney disease, they're telling us that their quality of life, if you will, is not as good as kids with diabetes or kids with heart disease, and maybe the same as kids with asthma. But if they go on to dialysis, you could see they say the quality of life is really poor, again, poorer than all these other disorders. So to me, this emphasizes the fact that we need to do a better job in understanding those factors that influence the quality of life in kids so that we can aggressively and successfully treat them. Now, what are some of the factors that lead to a suboptimal quality of life in the kids? This is from a study where we actually asked teenagers about, again, those factors, and these are all teenagers with chronic kidney disease. As you can see, some of the factors were they had an impaired body image, they had a sick identity, they felt vulnerable, and they had some doubts about their future. They felt that they were deprived of freedom and that they had lost opportunities. This is what they were telling us. And sometimes these things are under the radar and they don't talk to other people about them. Ideally, we would like them to develop autonomy and empower them and, again, see them they developing increased maturity, but sometimes that's difficult to do. And so it's important, again, when we recognize these things, that number one, that the kids talk to their parents about these issues, but this is where the team comes into play again. The nephrologist can be helpful, but oftentimes the psychologist can be exceedingly helpful in giving these kids strategies to address these concerns they have with respect to their underlying disorder. On our team, we have a regular psychologist that regularly meets with many of our patients to help address some of these issues, which again can have a significant impact on the quality of life of these kids. What about the whole family's quality of life? Well, this is from a very recent study from friends of mine from China that published about the impact of COVID-19 on families of kids who are on dialysis or who have been transplanted. You can see that 61% of the caregivers said they were having difficulties themselves. 79% said they were worried about the next couple of months. 13% were depressed, and 11% had anxiety. So oftentimes when we see families with children with a chronic disorder, the families themselves, the parents, are burdened as well with some psychological concerns. And I recommend that families, parents should also, again, seek out help when this happens, because the more, the better you're feeling from an emotional standpoint, from a psychological standpoint, as well as from a physical standpoint, the better you can be in providing the resources and support that your children need from you. When we look at children and, again, caregivers, children with chronic kidney disease, we now recognize they have different priorities in terms of what's important to them. And we as care providers need to recognize those differences so that we can address them. So in this study that was done out of Australia and really around the globe with children with chronic kidney disease, what are some of the important outcomes to these kids? Survival, of course, but sports, being able to participate in sports, fatigue, lifestyle restrictions in growth. Whereas when you look at the caregivers, kidney function, survival, infection, anemia, financial impact. So a little bit different in terms of what those priorities were, what was most important to these individuals. The kids themselves said what was important. They wanted to feel normal. They remained hopeful, but they had fear of invasive treatments. We as care providers need to recognize things, and you as patients and parents need to share this information with your provider so that it can be addressed in the most optimal way possible. This clearly can have a negative impact on quality of life, the mountain of medications. And some of you are probably not on many medicines, but others may be on a greater number. And sometimes we see, especially in teenagers, they're not getting all the medications they're supposed to. Sometimes because of the side effects, but sometimes because the kids just want to feel normal and not have to take those medications. Now, let me give you a look inside the brain of a teenager. Before that, we ask, why do they not take these medications? And again, now let's get into the brain. So here's the brain of the teenager. And so what's the largest part of the brain? Well, it's this part here that's focused on the birds and the bees. That's not surprising. And they have a great memory for music. They do love their parents, as you can see here. They have all the answers, and maybe in some kids, not your kids here in our centers, but maybe they may have a rebellion center. But this is their judgment gland. And you can see sometimes it can be quite small. And actually, this cartoon reflects some reality in terms of the physiology of brain development. Here we're looking at brain maturation. And what I want to emphasize to you is that the brain continues to develop over the first 3 decades of life until your mid-20s. And one of the more important areas of brain development is an area called the prefrontal cortex. Why is that important? It's important because that's where executive functions are developed. Now, what does executive functions mean? That's the area of the brain that controls impulsive behavior. It allows for emotional regulation. It allows for reasoning and learning from experience, knowing that if I do this, this might happen, and then planning. This is all so important when we're looking at taking multiple medications, controlling your own disorder. The kid's brain is still developing, and so here's again that partnership. It's got to be a team approach. It's the nephrologist, it's the nurse, but clearly it's the parents, the patient, and sometimes the psychologist working together to develop strategies to, again, optimize the therapy for those children. It's a team approach. Transition of care. This can be an anxiety-provoking time. And I want to differentiate transition from transfer. Transfer means moving from the pediatric center to the adult center. The transition is the education that we provide our kids so they can develop self-management skills. It's education that starts at around 12 years of age in the pediatric center and continues up to and maybe into adult care. It's extremely important, and it has a significant impact on the successful outcomes. By definition, healthcare transition, the purposeful, planned process that addresses the medical, psychosocial, and educational needs of adolescents or teenagers with chronic physical and medical conditions as they move from child-centered to adult-oriented healthcare systems. This just doesn't happen by the seat of our pants. It has to be a planned process between you, the patient, the family, and your center. Thankfully, there are guidelines to help define how this might occur. And these are guidelines that have been developed by the International Society of Nephrology and the International Pediatric Nephrology Association. This is, if you will, an adult medical journal. This is a pediatric renal medical journal. So all of the practitioners are aware that these guidelines do exist, and they should be implemented in all of your centers to help prepare you to move from pediatric to adult care. And at the end of that education, this is what we hope happens. A lot of things that are achieved by our young patients. They understand their condition. They know their medications. They know how to make arrangements at the adult clinic. They know who to call in a medical emergency, and so on. A number of different competencies that they should learn with this education that can occur over years. And in my center, we track that. And so here we have the transition patient readiness tool. And you can see it's divided up into 6 different categories. Information, the most important information as it relates to chronic kidney disease, medications, lab information, health, self-management skills, and insurance. And we track how well that child is learning these different components of their transition curriculum so that by the time they move to adult care, they are in fact well educated. Now, do keep in mind that all the adult providers don't feel comfortable taking care of children with pediatric-specific disease. This is a study of 62 internists. You can see that about 40% said they weren't comfortable taking care of these kids, and a little over 20% said, well, they were somewhat comfortable. So how do we address this issue? We meet with the adult providers. This is my center, where on a regular basis, at least annually, we have my team meeting with the adult teams. And we do that so that we can teach them about young adults with chronic kidney disease, and they can teach us about how they manage young adults on the adult side of things. And that shared learning, again, that teamwork allows for the best possible movement from pediatric to adult care with very few bumps in the road. So I think you can see that the emphasis of my presentation has been, there's a lot of things that we need to address. There's a lot of balls in the air at the same time. But most importantly, I think, is the team approach and the partnership. That is critical to the outcome. But one thing I want to emphasize, again, when we look at this team approach, is the interaction between the team members. And when I've asked individuals about this, we form this word cloud. Communication is also important. Education is important. Decision-making important. But most important is health literacy. What is health literacy? Reading, understanding, and using health information and instructions. It's exceedingly important that you understand what your providers are telling you. Because if you don't truly understand it, the likelihood of success is compromised. In my own program, we regularly conduct what we call teach back. And what is teach back? We will teach you something in the clinic, and then we will ask you to repeat in your own words, what did we just teach you? If you don't understand what we taught you, that's on us, not you. We have to take a step back and make it clearer so that you understand. We then reteach you, again, ask you to repeat in your own words what information we gave to you, and that continues until we're satisfied that we're all on the same page. And what I want to emphasize to all of you is never shake your head that you understand something your provider told you if you don't understand. Please tell them you don't understand. Don't be embarrassed. Again, it's on them to make it more clear, and in the end, that will, again, lead to much better success in the treatment your child or you, in fact, receive. And again, just an example, if someone said, we need a stool sample from you, again, you need to know what they're talking about. Again, health literacy is also important. I'm going to conclude my presentation with this slide here. So I showed you Children's Mercy Hospital, a picture from several years ago. This is our brand new research building, not yet open, but will open in early 21. And as Lisa suggested at the beginning of the presentation, I am very hopeful that the next meeting of the Alport Syndrome Foundation, the next face-to-face meeting, will occur in this building in Kansas City. So thank you very much.
Thank you so much, Dr. Warady. I always learn so much from having and from speaking with you. We have so many questions. I just want to make sure that everyone knows, that the audience knows, that Dr. Warady will be moving over to the virtual cafe when we have to take our 15-minute break to put the next live session in order. So you can also ask your questions there if we run out of time. I'm going to start with a couple things here. One is directly related to your presentation. A few questions have been asked about should pediatric Alport patients be given calcium or vitamin D to help their bones at any stage of disease or just near end stage renal failure. Also, if you could just let us know if your blood pressure slide was Alport patients or all CKD patients. And then we'll move on from there. But I want the audience to know we'll keep this going during the 15-minute break in the virtual cafe with Dr. Warady. And of course, we hope to have a follow-up webinar with just Dr. Warady at some point soon. Dr.
Glad to
Warady?
do it. Glad to do it. Yes. So good questions. So calcium and vitamin D, well, we want all the kids in general to receive the DRI or the RDA of calcium. And vitamin D is very much dependent, or the need for vitamin D is very much dependent upon kidney function. I should mention that there's two forms of vitamin D. There's nutritional vitamin D, and then there's the what we call active vitamin D. So many patients are deficient in nutritional vitamin D, which is vitamin D that comes from diet and from the sun. And so all of the kids should have that vitamin D level measured. And if they're deficient, they should get vitamin D. But some children, even with normal kidney function, are deficient in nutritional vitamin D. The active vitamin D is most important as the kidney function decreases. And as kidney function decreases, it's important because the kidney has a role in, again, manufacturing active vitamin D. So as the kidney function worsens, then the vitamin D needs will increase. And your physicians or nurses should be able to monitor blood tests to be able to tell you whether active vitamin D or nutritional vitamin D is required. And then as far as the blood pressure slide, no, that slide was from a study called the Chronic Kidney Disease in Children study, which is a study that I run. It's a national study of over 1,000 children with chronic kidney disease. But those are children with chronic kidney disease of all types. But I think the message here is that irrespective of the cause of your chronic kidney disease, whether it's Alport syndrome or one of a number of different disorders that causes chronic kidney disease in children, poor blood pressure control will worsen kidney function. And so that is one of the areas that we absolutely can manage. And by managing it, we will slow the worsening of kidney function in those patients. So blood pressure management is a key aspect of all patient management of children with kidney disease.
Excellent. Oh, I have a question. A couple people wrote in that your slide about X-linked Alport syndrome, Dr. Warady.
Yes.
A couple folks mentioned X-linked. What about X-linked fathers to daughters and those daughters to their children? Can you take a moment?
Yeah, so remember when the fathers who have X-linked disease, to their daughters are going to have, again, two X's, right? And so they will not have the syndrome like the X-linked fathers do, because X-linked fathers have an X and a Y. And if their X chromosome has that mutation, then they'll have the full-blown Alport syndrome that, again, leads to the end-stage kidney disease in all those individuals.
And one question that comes up often with all of us parents: how do we help our children not see themselves as sick? I know you speak to parents a lot about that. Can you take a moment to discuss that?
Yeah, I mean, I think it's a great question, and I think that's why I've tried to emphasize the importance of quality of life. And I think, we have to recognize that kids with Alport syndrome, there is a burden associated with that, whether it's their chronic kidney disease, whether it's the hearing abnormalities, and certainly there's the need for medications. And so I think that, number one, we have to understand the children. We have to talk to the kids. Some slides I sometimes use as a picture of an iceberg with a little bit of the iceberg above the water and the rest of it below the water. And sometimes I think, again, what we know about the quality of life in some of these kids is, if you will, under the radar. And so we have to be able to understand their problems, which in large part requires the kids to share their concerns. And that's when I regularly involve my psychologist, because, she regularly meets with children with chronic disorders. And I think that she can help them better understand not just the burdens of their disorders, but also the strengths in them as individuals. And I think there's usually more strengths than there are burdens, if you will. And then she can help them develop strategies to sort of overcome, if you will, that burden, not to remove it because the burden is there, but how do you cope with it in a positive way so that you're looking at more of the positive aspects of life as opposed to functioning on those things that strictly associated with disorder. You want to be an individual that has the disorder. You don't want to be controlled by that disorder. And that's something we work on. Not an easy fix. There's no magic medicine for that. But I think, again, sharing the feelings, sharing the concerns with somebody who can provide strategies to cope with these issues, I think is most important. And that's why I think a psychologist should be part and parcel of any program that cares for children with chronic kidney disease.
Thank you so much. We only have a couple minutes before we move over to the virtual cafe. So I do want to address for the audience, there are some genetic questions here. If you haven't had a chance to watch Dr. Simon's Alport overview video, please do watch that. He gets into genetics. And also we plan to definitely do a follow-up meeting webinar just based on genetics. Someone asks, is there biological or development milestones, Dr. Warady, instead of just age, that indicate when kids are ready to switch to adult nephrology? And we have about 2.5 minutes left.
2.5 minutes. Okay. I don't think that there in general should be a specific age when patients go there. I mean, it may generally it's between somewhere between 18 and 22 years of age. I think you need to look and sort of see what the patients and the parents want to do. I always look at how educated are they, how well have they worked with that, if you will, transition curriculum, that education, how prepared are they to move to adult care? And I look and sort of see, are they having any complications? I never want to transition or transfer somebody in the midst of some acute complications. I like to transfer them when they're medically stable and when I think that they have the education that they need to be successful when they move to adult care. So again, it's an individualized approach, and it's something that should be discussed, again, not at the 11th hour, but should be discussed over time with your healthcare providers.
Excellent. With about 1.5 minutes left, we are going to have a meeting just about diet with our dietitian, with a dietitian who's fantastic, going to speak about renal diet in one of these live sessions. But folks are asking about whether you think moving to a plant-based diet in pediatrics is helpful.
Wow, I'll be looking forward to listening to the dietitian. In fact, my wife's a dietitian. I don't know that I would necessarily recommend just a plant-based diet. I mean, I think what we have to do, especially in growing children, is to look at any diet modification and decide, are they receiving the necessary nutrients to grow and develop? I think that's most important. And so I think any kind of modified diet clearly needs to be discussed, intensely with your dietitian to make sure that all the necessary needs are in fact being met for those kids.
Okay, and is low blood pressure, from your perspective, is low blood pressure of concern pertaining to worsening kidney function or high blood pressure? Same question. If we see a difference in blood pressure, do you feel like that's of concern with the disease?
Well, generally, if your blood pressure is really too low, the kids are going to be symptomatic. They'll be dizzy, they will be sleepy, they won't feel good, and that's when the blood pressure is too low. But by far, the most common problem is blood pressure that's too high. And in most cases, the kids aren't having symptoms from high blood pressure, but when you measure it, it's too high. And we know that has a negative impact on your kidney, and it has a negative impact on your heart. So controlling high blood pressure to your best possible means is most important. And I think in the Alport's population, generally we recommend the maximum tolerable dose of the ACE or ARB medications to, again, help control worsening of kidney disease and at the same time helping control blood pressure.
And how often should we be checking for our children's eGFR?
Well, generally at every visit, every time that your child has blood tests and they get a creatinine level in their blood tests, you can estimate the GFR. And your healthcare providers can show you how that's done. It's a very simple equation. And there's actually even an app, a National Kidney Foundation app on a smartphone that would allow you to put in the information about your child's creatinine level, their blood creatinine, and that will estimate the GFR. But every time the blood tests are done, you should be asking your physician, your nurse, what is my child's or what is my estimated GFR?
Thank you so much.
You're welcome.
Are there any last thoughts you would want to leave us with, Dr. Warady?
No, I just want to say I hope you all are wearing your Alport's hat over the next couple of days. I know I will be wearing mine. I would have worn it during the talk, but you might not have seen my eyes.
Thank you, Dr. Warady.
You're welcome.
We appreciate your time.